Thank you so much for inviting me to share our story with hepatitis C testing and treatment here today. I'm Cabell Jonas, and I'm a research scientist and the director of research programs with the Mid-Atlantic Permanente Medical Group, part of Kaiser Permanente Mid-Atlantic States in the Washington, D.C. area. So to provide a little bit of context about our health system, Kaiser Permanente Mid-Atlantic States is an integrated care delivery system, and we serve over 800,000 patients in the Washington, D.C., Maryland, and Northern Virginia area of the United States. Um, we do have about 1,600 employed primary care and specialist physicians and over 250 non-physician staff. I am part of the Mid-Atlantic Permanente Research Institute, which is our embedded research institute within the Mid-Atlantic Permanente Medical Group. And so I'm going to share our journey with hepatitis C testing and treatment out here in the Mid-Atlantic States region of the United States. So this journey really started back in 2014, and it was primarily driven by the United States Preventive Services Task Force recommendation that baby boomer age patients be screened one time for hepatitis C. Um, there were also some other factors that contributed to our redesign of our hepatitis C screening and testing pathway. So in the United States, a new technology became available, transient elastography or FibroScan, to be able to assess liver stiffness without an invasive test like a liver biopsy. At the same time, around 2014, the first curative medications for hepatitis C also became available. Inside of our health system, there's a few pressing factors that led to specific redesign elements for this program. So, for example, we were looking to close specific gaps in care identified by the literature for Hep C testing and treatment. We were also looking at ways to shift tasks from physicians to other care team members, making sure that each care team member could practice at the top of their license. We were also looking for innovative ways to deploy virtual care to support our patients and physicians. And then lastly, we were looking at opportunities to streamline our laboratory testing process to make hepatitis C testing very easy for patients. And so I'll start here with our results from this program. If you look at our journey from 2014 to now 2024, we started with a little over 20% of our baby boomer population having had hepatitis C screening. At this point in 2024, 90% of our baby boomer age patients have had hepatitis C screening at least one time. We've seen similar increases in terms of patients aged 18 to 79. Of course, this is the additional USPSTF recommendation to screen patients age 18 to 79 once for hepatitis C in the United States. So additionally, you've seen our journey start at around 42% of these patients having been screened, and now in 2024, we have about 77% of this population that has been screened one time for hepatitis C. And so how did we do this? This is an overview of our hepatitis C screening pathway, and I'll walk through this. This is a coordinator-supported cascade of testing and care. And so in the upper left-hand corner, this is the step at which we identify patients that might need hepatitis C screening. So it can be a patient age 18 to 79 per the recommendations, or any patient that's at risk for hepatitis C can be tested through this program. So the program starts with the physician initiating the testing program by placing an order. And this order might be in response to an electronic record-based alert for someone age 18 to 79 or at risk, or they can just search for the order and place it. If the initial antibody testing is negative, the physician would then communicate that directly to the patient, and it's also released through the medical record. If the initial hepatitis C antibody is positive, it's automatically reflex tested for Hep C RNA, hepatitis B surface antigen, and HIV antibody. So when the patients come in, they actually give 2 tubes of blood in that initial visit so that we are able to do that reflex testing without asking patients to come back for a second blood draw. Patients that are identified to have HIV are immediately referred to infectious disease so the patient can be handled and the HIV can be taken care of in addition to the hepatitis C. For patients who are hepatitis C antibody and RNA positive, they're referred into this program, where, as shown in the upper right-hand corner, the hepatitis C care coordinator shares the diagnosis with the patient. They order additional hepatitis C laboratory tests and order the FibroScan to assess liver fibrosis. They also share informational sheets and a video that I'll talk about later. Um, Once the patient has had that conversation, they move along the program into the bottom left, where they come back to the lab for those Hep C assessment labs shown in the box. They also go to the gastroenterology department to have the FibroScan assessment of their liver. Coming out of that, they're given a fibrosis stage, and patients are referred to gastroenterology. If a patient for some reason is not interested in treatment, they may also have their treatment deferred through primary care. But for the most part, patients are very interested in treatment and they're referred to gastroenterology, where they would start treatment, undergo monitoring in collaboration with a clinical pharmacist, and if they are appropriate for a hepatocellular carcinoma surveillance program, they would enter into that program as well, shown in the bottom right-hand corner. And on this overview of the program, I just wanted to note that the boxes in blue are the steps that are handled by the hepatitis C care coordinator, and the boxes in black are the steps handled by the physician. So we really tried to make this very hands-off for the physician and have the coordinator really step in to provide that care. So this program was specifically designed to close gaps in hepatitis C screening and care that had been identified in the literature and in clinical practice. So I've shown some of these gaps here. Of course, a very well-known gap is the issue of antibody testing and RNA testing being single tests. Implementing a reflex test for those was a key priority for this program, and we were able to do that by having the 2 tubes of blood drawn and then have the positive antibodies be reflexed to the RNA test. We also implemented co-infection testing for Hep B and HIV to be sure to detect co-infections. Communication of a Hep C diagnosis was a gap from the literature. So that was part of the design of the coordinator supported pathway, is making sure that that coordinator was able to reach out to the patient, accurately explain the diagnosis, and answer any questions. We also implemented the appropriate assessment labs and the liver stiffness assessment per literature guidelines. And we wanted to be sure to give a warm handoff to gastroenterology to make sure that that patient could access a management plan and hepatitis C curative treatment. And as I mentioned, we do have a program that connects to this one that supports ongoing liver cancer surveillance. So, what were the key components that led to our program? So, the first thing I wanted to talk about was leadership support. We did have strong leadership in the Mid Atlantic states that was very supportive of both testing patients for hepatitis C and treating patients for hepatitis C. This team supported our initial baby boomer based screening efforts and then was very supportive of the expansion of these screening efforts to the 18 to 79 testing group. Our region was an early adopter of the FibroScan technology. This allowed our physicians to access a non-invasive fibrosis assessment tool, and patients were very enthusiastic about being able to access this test in a non-invasive way. Our leadership also did provide nurse coordinator support time to be able to build a pathway that relied heavily on nurse coordinators and really preserved the physician time for the activities that required the physician expertise. So the second piece that I wanted to focus on as a key component was that reflex lab testing. We developed this in-house, but in the United States, there are many commercial labs that do reflex lab testing at this point. Um, the main benefit for the patient is that instead of having to go twice to the lab, they now only have to go once, give that initial blood sample. For us, it's 2 tubes of blood, and then be able to get both the antibody test and the RNA result with the same samples and be able to get a complete diagnosis. So you don't have that gap of patients that got the antibody test and never came back for the RNA test. So this was a key component of this program that has contributed to it. For this particular program at our site, the patient goes for the initial laboratory blood draw, and then they come back if they're positive. for the Hep C assessment labs for a second laboratory blood draw. And on that same day, they typically do the fiber scan. So we're able to reduce the number of total visits for our patients to make sure that they're coming to the clinic as little as possible and are maximizing those visits to the clinic and getting them the maximum diagnostic information out of it. When our patients see gastroenterology, they also have the option to go in person or they can do a virtual visit with the gastroenterologist. I showed the graphic of what the entire program looks like, but I always like to point out for an ordering physician, this pathway actually looks quite simple, and that was intentional to its design. So for the physician, they simply order the program initially in the medical record. And then if their patient is positive, they're sent a message at the end of the program, letting them know the updates from the coordinator, that the coordinator has completed all the testing with the patient, that the patient has been sent to gastroenterology, that the visit has been completed, and that no action from the primary care physician is needed. So primary care physicians really like this program. They like that they can do the right thing by initiating screening and ordering screening on all their patients, but that the coordinators are really handling all of that care coordination and management, making sure those patients receive a communicated diagnosis, making sure the positive patients come back for those assessment labs, making sure they complete the fiber scan, and then making sure that they actually reach gastroenterology and have that appointment and then can be triaged to treatment. So those are all things that we put on the coordinator so that the primary care physician was simply placing the order and then knew at the end of the program that their patient had completed all of those steps. So physicians are very supportive of this program in our system. So what does the nurse coordinator support look like? So we have two full-time nurse coordinators right now for our system, and they handle about 30 to 40 chronic Hep C patients a month. Um, And again, their main activities are communicating the hepatitis C diagnosis to the patients, ordering those labs and the fiber scan, sharing educational information, and answering patient questions. Patients often do have a lot of questions about hepatitis C, and the coordinators are able to spend that time answering all of those questions and making sure that the patients really understand the diagnosis and understand the next steps and how they'll proceed through the rest of the system. And as I mentioned, the coordinators do provide care coordination support through to the gastroenterology specialist appointment. Once they're in gastroenterology and pursuing treatment, in our system, we have a clinical pharmacy team that supports treatment management. And so they are passed to the treatment management team to make sure that they complete their treatment. And then, as I mentioned, we have another liver cancer surveillance program that they would connect to if they're eligible for that screening. So this slide just digs in a little bit about the coordinator activities. Um, all of our coordinator support is provided virtually, so it is telephone-based care. We have one RN level coordinator and one LPN level coordinator. And so they do share the diagnosis via phone with patients. They are given a lot of time to explain the diagnosis and answer questions. They give patients informational content and follow up. We have information that is conveyed through the electronic medical record, and they can also gather and provide additional information as needed based on the patient's questions as well. The patient receives the coordinator's direct phone number. Again, for us, we want to make sure that these patients are linked in tightly with this program. And so the coordinator and the patient are in close contact via phone, so the coordinator can make sure that the patient can make it through all of these steps in the program. And as I mentioned, the care is coordinated through that final specialist appointment. So these are some examples of educational sheets we've made for the various individuals who come through this testing pathway. On the left is the general educational sheet that we provide to all ages of patients. It's a fairly general overview of hepatitis C. It explains the diagnosis. It explains how the person can care for themselves and receive more information. On the right, we actually also created a baby boomer age specific informational sheet. We found that baby boomer age patients had slightly different questions and concerns than other age patients. And so while the two informational sheets contain all of the same information. It is ordered in a different way and sometimes explained in a different way to be able to emphasize the answers to the questions that our baby boomer patients most often had, and be able to put that content a little bit more forward with those patients. And so we've been able to provide really custom sheets for different groups to make sure that we're meeting their clinical needs and informational needs. So the journey of this program has been published. We have a few publications shown in the bottom left-hand corner, starting with the initial overview of the program through to some outcomes from the program. I did want to show this table from our recent publication, indicating that when we looked at patients making it through each step in the Hep C testing program, we did find that more patients in the hepatitis C pathway program completed each diagnostic step, so made it to the FibroScan, made it to the GI visit, made it to treatment, and actually more patients made it to treatment through the hepatitis C program than in usual care. So in our system, the hepatitis C program is now the standard of care for all of our patients. And so anyone tested for Hep C who is an adult 18 and over will be tested through this hepatitis C testing program. So at this point in our system, 79% of our hepatitis C patients have been treated. And because this hepatitis C program and the coordinator supported nature of it has been successful with our patients, we have expanded this program to address other conditions. So, for example, we have a hepatitis B testing program that, again, utilizes coordinators to support patients in being tested for hepatitis B and monitoring hepatitis B diagnosis and triage to specialist care. And then we also have a liver cancer surveillance program that, again, has coordinators support patients in accessing ongoing surveillance if they need that surveillance. So accessing the ongoing imaging and lab testing required to monitor patients at risk for liver cancer. And so those two programs are also part of our liver cancer care program here, and we have coordinating publications with those as well. As I mentioned, we've shared our journey publicly. We're always happy to answer questions about the program and share more about it, but there is a fair amount in the literature about this program and some of the outcomes that we've received. But we would encourage any interested individuals to reach out to us, and we're happy to answer questions and share more about the programs. Um, and I did want to, again, thank our leadership who was instrumental in helping design and sustain this program. I also wanted to thank our coordinator team who does just an outstanding job with patient care, as well as our collaborating departments, particularly gastroenterology, infectious disease, primary care, our laboratory and technical teams, as well as the Research Institute team. And so thank you so much for inviting me to share today, and I look forward to hearing questions. Thank you.